Hi, my name is Kimberly Wynn. I am a student at Winston-Salem University. I am currently studying to be a clinical laboratory scientist. I am here today to present to you a tool to improve antibiotic stewardship in the pediatric population by the usage of Procalcitonin guided therapy. So, according to the CDC, there's more than a 2.8 million antibiotic resistant infection that occurs every year in the United States, and more than 35,000 people die as a result. And in addition to that, 200,000 are a case of C. diff. And then out of that 200,000, 13,000 people die from C. diff. And as most of you guys would know, that C. diff happens happens when you are taking antibiotics or an effect something that you get after you get off of antibiotics. And I'll go more into that detail, but just remember, 200,000 people are infected with C. diff a year. And out of that, 13,000 do die. So keep that fact numbers in your head and we'll come back to it. So the healthcare company do spend about $4.6 billion annually. This is the estimated cost for them to treat an infection caused by multi-drug resistant bacteria. So we really need to reduce the usage of administering antibiotics therapy. It's a very serious topic in the healthcare. The studies have shown that 30 to 50% of antibiotics given in the hospital may have been unwarranted. The incorrect usage of antibiotics can often lead to development of antibiotic resistant or complications associated with them, such as C. diff. If you take too much antibiotics, it could cause C. diff. And the severity and the occurrence of C. diff infection due to the overusage of antibiotics has dramatically increased within the past 20 years. So, like I said before, like 30 to 50% of antibiotics given in the hospital are unwarranted. The misuse of these antibiotics in the pediatric and the neonate population, studies have shown that that population will develop obesity later in life. They will develop asthma, dermatitis, and a lot of nosebleed by the age of 5. So that is what we have known so far. So moving on to how the hospital do test for infections. So the golden standard for testing if a patient has any type of infection would be the blood culture. But unfortunately, the blood culture has a turnaround time results that are too long and ineffective, considering that 50% of the death from infection does happen within 3 days. Therefore, Procalcitonin is the most common biomarker used as an indicator for infection, since it quickly rises within 2 to 6 hours and will decrease steadily after the introduction of antibiotic therapy. So the decrease of the usage of Procalcitonin in the neonate intensive care unit and the pediatric intensive care unit, as they are quickly prescribed by the physicians and the doctors there, only because this is to ensure their safety in that they're there and they're sick, right? So we have found some studies that have been done, and so the first study that I found that in 2017, a group did a study. So it was a group effort between Switzerland, Canada, Czech Republic, and Norway. They took a look into the stewardship in the relationship to neonates. So they were able to select 1,400 neonates total. 745 of those neonates were in the Procalcitonin groups, and then the 663 were the standard group. So they follow their standard protocol, which is they get admitted into the hospital, they get collected once they come into the hospital. But the neonates that were in the Procalcitonin group did have an additional blood drawn at the 12-hour mark. And all of the samples were run in duplicates. So the instrument that was used for this stewardship was the Creptor and the Roach. And the results were that the duration of the antibiotic treatments was decreased by 10 hours. So there were some good results from that, but it also seems that once the study was done, the physicians did not continue the protocol. And then another study I found was in China, which was focused on 14-year-olds with lower respiratory tract infection, and they did it in two stages. And so the first stage was from January 2010 to December 2013. Roughly 147 patients were diagnosed with lower respiratory tract infection and was treated with the standard antibiotic therapy. And then the following second stage of the study, they used the data that they collected from the previous stage 1. The second stage started from January 2015 to July 2016. Roughly 183 patients were diagnosed with lower respiratory tract infection, but with the additional Procalcitonin testing in this group, the second stage group. And the antibiotic prescription was at roughly an 80% from the first stage, and first stage of data collecting has dropped down to 55%. So the duration that these pediatric population exposure to antibiotics were reduced from 6 days to roughly 4 days. So we're going to go into the methods of how I would want to collect data. The method that I am presenting today would be a year-long study at a single center at a pediatric patient in the PEAK or the NICU located in Asheville, North Carolina. The Procalcitonin group of stewardship would be used in conjunction to the clinical studies, and the examination of the patients will be the Procalcitonin group. The standard group would be the pediatrics patients who have met the inclusion and exclusion criteria and who are been admitted and treated with antibiotics during the previous years. So the requirement for the study for the pediatric would be that they must be 18 years old or younger. The patient must be prescribed and administered antibiotics at the hospital and no longer than 24 hours prior to enrollment to the study. And of course, the parents have to consent. Since these are pediatric patients. Patients who are going to be excluded would be patients that do not need antibiotics during the hospital stay, patient who have a primary or secondary immune deficiency, patient with cystic fibrosis, patients who have an HR or any infection, and neonates that are under 5 days old. So patients who are suspected of having an infection, the specimen would be centrifuged down for 10 minutes at 35 RPM and within 30 minutes, and be tested on a 16,200, an instrument kind of like this, not the exact one, but very similar, or the Cryptor 0.2 thousand. So entitled for us to run it on these instruments, we would need at least 150 microliter sample, and the length of the testing would be at least 22 minutes. All the samples will be run in duplicates. Patients that has a procalcitonin of less than 0.1 nanogram will be not administered antibiotics. Any patient who has between 0.25 to 0.5 will be given antibiotics, and any patient with greater than 0.5 nanogram will be given will be placed on antibiotics. The procalcitonin will be repeated 2 to 3 days, and if the patients drop by 80%, then we will stop usage. So then, like, we are here to see if they will have any bacteria septic. So anything from 0.1 to 0.5, the likelihood of septic is very low. Anything greater than 0.5 possible septic with a history of septic will be encouraged to take procalcitonin. So the data will be collected and will be compared to a Pearson and Wilcoxon we're gonna see if the patient has a bacteria septic. So anything from 0.1 to 0.5 is the low likelihood of septic, versus a patient with greater than 0.5 possibly septic with a history of septic will be encouraged to take procalcitonin. Data then will be collected, and the comparison will be done by the Pearson X2 and the Wilcoxon. Any difference of less than 0.05 will be considered significant. The evaluation will be like exactly how likely it is that any observation difference between the set arose by chance, and then the comparison between two related samples, or the matched sample, or the repeated measurement of a single sample to assess whether the population meets the rank's difference. So the implementation of the Procalcitonin guideline antibiotic stewardship in the NIC and the PEAK will decrease the antibiotic therapy along with decreasing the length of the stay. So by the end of this research, I hope to be able to establish that a stricter guidelines for treatment procalcitonin in the neonate and the pediatric population, and that by not overusing antibiotics, this will allow these population to grow up and not have so many drug-resistant bacteria that will cause them bad health later on in life. So thank you.